Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the pleasure of inviting onto the podcast Henri Azaïs, who is in the Department of Gynecological Oncology and Breast Surgery at the Hôpital Européen Georges Pompidou in Paris, France, the Université Paris Cité, Carpem Cancer Institute in Paris, France. And also he's at the University Paris Cité Center de Research de Cordelier. The topic of this podcast is going to be on a recent article, obviously a very relevant topic today, titled Clinical Value of Circulating Tumor DNA for Patients with Epithelial Ovarian Cancer. Henri, welcome to the podcast, and thank you so much for accepting our invitation, and of course, obviously, for submitting this really great review to our journal.
Thank you very much for your invitation. It's an honor to discuss with you the current and future role of ctDNA in the management of patients with ovarian cancer. Just before answering your questions, I would like to thank all my colleagues who are working with me on this exciting research, as well as all the patients who have placed their trust in us to make progress this field of research.
Excellent. Thank you so much for that introduction as well, Henri. Looking forward to discussing a lot of these topics that, of course, as I mentioned, are very relevant and often a topic of discussion in tumor boards and with patient counseling as well. So I wanted to start by discussing why is ctDNA a potentially useful and different biomarker than what we already have, like CA-125, Gallium score. In addition, can you define the term liquid biopsy for those who are not familiar with this terminology?
Yes. ctDNA is a biomarker that offers distinct advantages over traditional markers like CA-125 and the Gallium score. And unlike CA-125, which is not specific to ovarian cancer and has a long half-life, ctDNA provides a more direct and real-time snapshot of the tumor's genetics landscape. And this allows for both quantitative and qualitative assessments of the tumor burden. ctDNA can detect specific genetic and epigenetic changes, offering insights into tumor heterogeneity and evolution, which are crucial for personalized treatment strategies. The principle of a liquid biopsy is to identify the characteristic of a tumor through the collection of a biological fluid, such as plasma, urines, acids, and with the aim of analyzing specific tumor-derived components released by the tumor, such as ctDNA, circulating tumor cells, or tumor-derived exosomes. This approach allows for repeated sampling and monitoring of tumor dynamics over time and providing valuable information for early diagnosis, treatment response assessment, and detection of resistance mechanism.
So now, Henri, can you tell us a little bit more about what exactly is circulating tumor DNA and how is it detected?
It's important to understand that all cells of healthy individuals release fragments of DNA called cell-free DNA into the bloodstream. In cancer patients, circulating tumor DNA or ctDNA represents a variable proportion of cell-free DNA and consists of small fragments of DNA released into fluids such as plasma by tumor cells through processes such as necrosis, apoptosis, or active secretion. These fragments carry the same genetic and epigenetic alteration found in the primitive tumor or metastasis. So ctDNA is detected using advanced molecular techniques such as quantitative PCR, digital PCR, or next-generation sequencing. And these methods can identify and quantify specific genetic or epigenetic modification present in the ctDNA. In the specific case of ovarian cancer, it is possible to search blood for a mutation that has already been identified in the tumor. This is a tumor-informed approach, which means developing a test for a given patient. And there is also a tumor agnostic approach that is based on the identification of frequent mutation, such as, for example, the search for mutations in the TP53 gene in high-grade serous carcinomas. Our team is working on this kind of tumor agnostic approach with the development of a methylation signature specific to ovarian cancer for the detection of ctDNA by digital PCR.
So now, Henri, we'd like to get into some of the questions that were sent in from our fellows in the journal. And this first question comes from Filippo Capomacchia, who is at Candiolo Cancer Institute in Italy. And he's asking, can ctDNA be employed to identify postoperative minimal residual disease in patients with advanced ovarian cancer who have undergone cytoreductive surgery? And at what time after surgery and with what testing frequency should ctDNA be assessed?
Yes, ctDNA can be employed to identify postoperative minimal residual disease in patients with advanced ovarian carcinoma. And this is the topic of one of our study. And according to this study by Mehdi Ben-Sassi et al., ctDNA detection and monitoring provide valuable insights into the presence of residual disease after surgery and after first-line therapy. And this study demonstrated that ctDNA levels at the end of first-line therapy are significantly associated with the prognosis of patients. Patients with detectable ctDNA at the end of treatment had a poorer prognosis compared to those without detectable ctDNA. My opinion is that the optimal time to assess ctDNA levels in order to assess minimal residual disease is at the end of the first-line treatment sequence, which typically includes cytoreductive surgery followed by chemotherapy. This timing would allow for an evaluation of the effectiveness of the treatment and the presence of any residual disease that might not be visible through imaging. The half-life of ctDNA is very short, around 2 hours, so it reflects the tumor burden in real time and could be measured very soon after surgery or any intervention. To date, there are no real recommendations concerning the use of such a test or its frequency of use, and this should be explored in prospective trials.
Now, this question comes from Natalia Tejeda. She's at the hospital clinic at Barcelona. And she says, this review shows that ctDNA can detect recurrence well before clinical or radiologic evidence. But in practical terms, how actionable is this early detection? Should we intervene in an asymptomatic patient with ctDNA detected recurrence, even when imaging is negative?
Well, I don't think so. Early detection of recurrence through ctDNA would allow clinicians to consider therapeutic intervention before clinical symptoms or radiographic evidence. But however, the decision to intervene in asymptomatic patients should be carefully assessed, as early treatment in asymptomatic patients has not been shown to improve survival rates, and I think it could lead to overtreatment.
So then as a follow-up to that, Frederique Stroisch from Heidelberg University Hospital, she's asking, compared to CA125, what, in your opinion, is the key advantage of ctDNA? And based on this, in which clinical setting do you believe it holds the greatest potential?
Well, the key advantage of ctDNA over CA125 is its specificity and ability to provide real-time quantitative and qualitative information about the tumor. ctDNA holds the greatest potential in assessing sensitivity to chemotherapy and in measuring residual disease to help define the risk of recurrence. I think this may help to specify the modality of follow-up, maintenance strategy, to consider de-escalation in the absence of ctDNA detection, or conversely, to intensify treatment if significant residual disease is detected.
So now this question comes from Rima Buchakra in Hotel Dieu de France. A study showed ctDNA can identify recurrence up to 10 months before imaging or CA125. How should we respond to these early indicators practically? Should we aim for an intensive surveillance and induce treatment, preventative treatments, while considering that early treatment in asymptomatic patients doesn't really improve survival?
Yes, I do. You just said there is currently no survival data from prospective trial confirming the prognostic benefit of using ctDNA over CA-125. However, ctDNA does offer more specific detection capabilities, allowing for more precise monitoring of the disease. And while early treatment in asymptomatic patients has not been shown to improve survival rates, the enhanced specificity and real-time monitoring capabilities of ctDNA could potentially allow for better informed clinical decision and maybe would make it possible to anticipate the occurrence of a recurrence and to personalize the use and frequency of imaging examination.
And I'll read this question back from Natalia Tejeda. She's asking with regards to screening methods for recurrence and looking at survival benefits. So she's more concerned about frequency of testing. And she said, how early in the disease course can ctDNA realistically be detected? And if used for screening, how frequently would we need to test asymptomatic women to detect cancer early enough to impact outcomes?
The question of screening is very important, as screening studies have shown that while we can diagnose a higher proportion of cancer at an early stage, this early detection has not translated into improved survival outcome. The challenge with ovarian cancer screening is the lack of access to a treatable precancerous lesion before the onset of invasive cancer. And I think that ctDNA could potentially allow for earlier detection of cancer, but there is currently no evidence showing an improvement in prognosis with this approach. Therefore, it is not yet feasible to propose such a test for the general population. We might consider offering ctDNA testing to high-risk patients, but these patients will likely benefit more from risk-reducing surgery, and in my opinion, screening is not the best application of ctDNA used at this time.
Great. So now, Henri, I'd like to turn over to the topic of drug resistance, and I believe you addressed this in your article as well. Is there a role for ctDNA in predicting drug resistance?
Yes, ctDNA may play a significant role in predicting drug resistance, as unlike solid biopsies, ctDNA can be used to monitor all tumor clones, thereby preventing and monitoring the development of treatment-resistant clones. And by analyzing genetic mutations and epigenetic changes in ctDNA, clinicians can identify mechanisms of resistance that emerge during treatment. An example is the case of reversion mutation in BRCA genes, which restore the protein function and have been associated with resistance to platinum-based treatment and PARP inhibitors. Monitoring these changes could help in adjusting treatment strategy promptly to overcome resistance.
Now, this question comes from Helena Obermeyer in Sydney, Australia. And she's asking, in your review, you discussed ctDNA's role in capturing tumor-specific mutations. Could you explain how ctDNA testing distinguishes between somatic and germline mutations in ovarian cancer? And how does the presence of a germline BRCA mutation influence the utility of ctDNA testing across different clinical scenarios?
Yes, ctDNA testing distinguishes between somatic and germline mutation by comparing the genetic alterations found in the ctDNA with those in the patient's germline DNA, typically obtained from peripheral blood leukocytes. So somatic mutations are those present in the tumor but not in the germlines, whereas germline mutations are inherited and present in all cells of the body. The presence of a germline BRCA mutation influences the utility of ctDNA testing by providing additional context for interpreting the genetic landscape of the tumor, helping to tailor treatment and surveillance strategies more effectively.
Now, this next question is an interesting question also, and it talks about neoadjuvant versus primary surgery, and this is from Rima Buchakra, and she's asking, could ctDNA be part of the risk assessment models at diagnosis to guide us on the management of the disease and making us decide neoadjuvant versus primary surgery?
In our work with the cohort of patients from the Shiva study that has been published this year, ctDNA was detected using next-generation sequencing. It's important to note that there was no correlation found between ctDNA levels at diagnosis and prognosis. Instead, it is the kinetics of the ctDNA marker that are pertinent, particularly in measuring the early response to chemotherapy or identifying residual disease at the end of first-line treatment. These kinetics are associated with prognosis. For this reason, at diagnosis, the decision to propose primary cytoreductive surgery or neoadjuvant chemotherapy should remain based on the assessment of resectability to obtain complete macroscopic cytoreductive surgery, considering imaging, information from an exploratory laparoscopy, and the patient overall health status. However, further development of ctDNA tools could allow for the rapid acquisition of a molecular profile, which would help predict the response to chemotherapy and thus influence the decision regarding the therapeutic sequence.
Great. So now, turning to the point of cost, Sofia Bigardi from Padova University Hospital in Italy, she's asking, the analysis you conducted, did you also take into account cost effectiveness of ctDNA monitoring? Considering its promise for prognosis and early recurrence detection, how do you envision its integration into clinical practice given real-world limitations such as cost, infrastructure demands, and variability in patient access, particularly in low and middle-income countries?
Well, the primary focus of our review was on the clinical value and potential for ctDNA, but you're right, the cost effectiveness is indeed a crucial consideration for its integration into routine clinical practice. ctDNA monitoring involves significant costs related to advanced technologies like next-generation sequencing and the need for specialized infrastructure and expertise. To envision its integration, it's essential to develop more cost-effective and accessible ctDNA detection methods. This could involve simplifying the testing procedures, reducing the cost of sequencing technologies, and establishing standardized protocols that can be widely adopted. Effort should also be made to ensure equitable access to these technologies, particularly in resource-limited settings, possibly through centralized testing facilities or partnership with specialized laboratories. The aim of our research is to develop a specific and reproducible test based on the detection of a methylation signature by digital PCR, which is an inexpensive technique to encourage the use of ctDNA and its implementation in clinical practice. Indeed, the advantage of ddPCR compared to NGS are its lower cost, high reproducibility, accessibility in any laboratory, and also the speed of the analysis.
So you mentioned reproducibility, and then it leads us to the next question from Sofia Bigardi. She says, in the analysis you conducted, did you address the technical challenges associated with replicating ctDNA assays across different institutions? Given the variability in assay sensitivity, standardization, and interpretation, how close are we to making ctDNA a reliable and reproducible tool in everyday clinical practice?
Well, you're right. The technical challenges associated with replicating ctDNA assays across different institutions are significant, as variability in assay sensitivity, standardization, and interpretation can affect the reliability and reproducibility of ctDNA testings. These challenges include differences in sample handling, DNA extraction methods, sequencing technology, data analysis pipelines. To address these issues, there is a need for some standardized protocol and guidelines for ctDNA testing, including sample collection, processing, and analysis. While progress is being made, achieving a widespread reliability and reproducibility in everyday clinical practice will require continued collaboration and research in the scientific community.
So now this question is from Frederica Stroisch, again from Heidelberg University. And she's asking, today, what do you see as the biggest challenge before ctDNA can be routine in clinical practice?
There are still many challenges to overcome. One or more validated tests specific to ovarian cancer should be developed to limit the variability between the techniques used. And the challenge includes addressing technical variability, answering cost effectiveness, and developing guidelines for clinical interpretation and action based on ctDNA findings. But guidelines should also be established for pre-analytical analysis, as the samplic tubes, plasma isolation, sample storage, and extraction of ctDNA are all parameters that can influence the results. Additionally, integrating ctDNA testing into existing healthcare systems and ensuring accessibility for all patients, regardless of their geographical location or socioeconomic status, are crucial steps to overcome.
So to that point also, Mariana Carvalho from Sao Paulo, she's asking, for epithelial ovarian cancer, where do you see the potential for ctDNA moving forward? Is it going to be in screening? Is it going to be in diagnostics? Is it going to be in surveillance?
Well, I believe that ctDNA will first be incorporated into the assessment of treatment response and chemosensibility in epithelial ovarian cancer. In this context, CA125 can also be used, but ctDNA offers additional advantages due to its specificity and sensitivity. For the detection of residual disease, ctDNA will be an excellent marker because it is much more sensitive. The absence of detectable ctDNA after treatment could help identify a subgroup of patients with a better prognosis. This capability to detect minimal residual disease could significantly influence clinical decision and patient management strategies, potentially improving outcome by allowing for more timely and tailored intervention. I think that screening is not the best application of ctDNA use at this time.
So now Luisa Prope from the University Hospital in Munster, she's asking, how could it become possible in the future to overcome these limitations of tumor-specific approaches such as time-consuming analyses and the need for very high-quality tumor material in order to assess and evaluate ctDNA?
This is exactly the purpose of our research. To overcome the limitation of tumor-specific approaches, future advancements could focus on developing more efficient and less invasive methods for obtaining tumor material, such as through improved liquid biopsy techniques. Additionally, technological advancements in sequencing and data analysis could reduce the time and cost associated with this analysis. Developing universal and broadly applicable ctDNA markers that do not require prior knowledge of tumor-specific mutation could also streamline the process and make it more accessible. This is the purpose of our research, developing a specific and reproducible test based on the detection of a methylation signature by digital PCR, which is an inexpensive technique to encourage the use of ctDNA and its implementation in clinical practice.
So now, Henri, as a last question to the podcast, this one comes from Rossano Nelia Marina from the European Institute of Oncology in Milan. And she's asking, do you see a future where ctDNA not only monitors disease, but also informs us about personalized, targeted therapies in ovarian cancer patients?
Yes, absolutely. I think that the future of ctDNA in ovarian cancer management is very promising for informing personalized targeted treatment. As our understanding of the genetic and epigenetic landscape of tumor improves, ctDNA can provide critical insights into the specific mutation and alteration driving an individual's cancer. This information can guide the selection of targeted therapies, monitor treatment response, and adjust therapeutic strategies in real time to overcome resistance and improve outcomes. I think that the integration of ctDNA analysis into clinical practice has the potential to revolutionize the way we approach ovarian cancer treatment, making it more precise and personalized.
Well, Henri, thank you so much for the time, the opportunity to discuss this article, the opportunity to discuss this obviously a very relevant and important topic, topic that we can't seem to get away from in any discussion in gynecologic oncology these days. So congratulations to you, your team, the work you're doing, and really exciting opportunities coming up in the future for the implications of ctDNA in gynecologic oncology, not just in ovarian cancer. So really, thank you again for your time.
Thank you very much. It was a pleasure.